like therapists, pharmacies, intrathecal baclofen, botulinum toxin, and surgical options. It's not working, this one. Okay, shall I move it manually? It doesn't work manually. Here. So it's not moving. If I come with mouse, okay, I'll do it manually. What's happening? This is next slide, but why it's not coming? What am I doing? I just pressed. Okay, see, back. All right, okay, yeah. So as we all know that CB is a non-progressive condition. It's mainly motor dysfunction, disturbance in mobility imbalance, caused by any damage to the brain during its development, which will be starting from throughout pregnancy to the end of the second year of life. And this is a condition which we call, again, non-progressive. Mainly, the non-progressive condition is related to the pathology of the CP. But many children, unfortunately, especially if we're not receiving the standard of care, they might show some regression. We know for sure that many children develop bad contraction with time. Many children being able to walk and then they lose their ambulation. If they became very heavy, if they became taller, they're not be able to manage their life. But the cause of the CB itself is non-progressive. So we've got asphyxia, perinatal asphyxia, PVL, all these things are very static, and whenever you repeat the scan, you'll find the same thing. Many things will be very much related to CB children. If we're starting with the joint spasticity, motor dysfunction, and then we're having many other cognition, communication, visual impairment, epilepsy. Dr. Majid spoke about it today morning. We have also other issues related to the GI issues, respiratory issues, renal issues, personal care, and even more than that, we've got everything will have more even branches related to it. For example, for GI, we've got GERD, we've got the nutrition, constipation, feeding difficulties, drooling, and then also there is a very sort of relation as cause and effect, and sometimes exaggeration between all these things. From this very chaotic slide, you could see that cerebral palsy is not one condition, I have to admit. It is one condition, but related many, many other conditions. And never the management of children with CB will be as one subspecialty. It's always multidisciplinary and always involving many other specialists, many therapists to be able to control and help with this condition. Now, talking about classification of CB, the most common one is the topographical one, which is going to say that it is, we've got hemiplegia on side, we've got diplegia affecting lower limbs more than the upper limbs, which is a typical pattern for children with prematurity and BVL, and we've got the quadriplegia. Spasticity itself, it is, in my feeling, that it is exaggerated stretch reflex. We all know that inside the muscle, we've got the spindle, and this spindle, whenever the muscle is stretched, it sends a message directly to the spinal cord, and through the anterior horn, we've got feedback to the muscle to contract. This will be naturally happening in the muscle all the time, but with a very good inhibitory control from the brain, where that the reflex itself is not going to be exaggerated, it's not going to be uncontrolled or increased. And because of that, when we have any damage, brain injury, even spinal cord injury, we will lose this inhibitory, or let's call it controlling effect from the upper motor neuron. And in this case, the exaggerated message to the muscle, making them contracting and spastic. So spasticity many times used as synonym of CB. So children say spasticity or CB at the same time, and sometimes could be used as a sign. And really, we need to distinguish between spasticity and other things. Dystonia, which is something we need to distinguish from. And I would like also to mention about contractures. Many times do have children with even sometimes a peripheral disorder. I mean, neuropathies having contracture can sometimes interpret as wrongly as spasticity. Now, the spasticity can be classified also similar to other things topographically, that to be as generalized spasticity affecting all the body, can be as regional, half of body or limbs, upper, lower, and it could be also focal spasticity. Now, to assess spasticity, we've got very few scales. I think the people working in neurodisability and working in physiotherapy would know more than me about this, but at least this is one of the most common scale to assess the spasticity, the Ashworth scale, which ranging from 0, where we have no resistance to passive muscle movement, so moving the limbs will have no resistance, and going to the very severe end, where we've got very marked increase in the muscle tone, and the affected part of the body will be really rigid. So you can't passively or will sometimes actively do any movement in it because it's really tight. The other type is the adductor also tone rating. It's again is from 0, where it is very easy to abduct, but we have to moving to, for example, in grade 3 or level 3, the hip adductor 45 degrees would need one person, but with strong effort. And then the worst one, that you need 2 people to be able to abduct the hip for 45 degrees. And this has a very bad effect on children, especially for hygiene and toileting. This as I would consider as affecting the care and function of the child. Tardio scale is another scale which also assists the movement and depending on the slow and the quick movement. And this will show that if, for example, if I have my hand, I'm moving it, very smoothly moving it without any resistance, that's fine. Starting to move it, but I start to have a little bit of resistance and clear in 2, level 2, we will start to have a little bit of catch, and then I will easily continue. So it's very minor catch, but at certain degree I got catch. And then the worst thing that when we have the sustained catch for about 10 seconds, and sometimes associated with microness, I'm bending my arm quickly, and then suddenly I can do it. And then the number 4, which is where after the clonus is not fatigable, it is continuous. So whenever we come to a certain degree, probably, and it keeps like that. More that you push is still shaking, so you can't bend up. So 4 degrees of catches and spasticity. There are other things, gait analysis, which is very essential, and that's for children, especially prior to surgery, considered for dorsal rhizotomy, tendon release, and things like that, will be important to do this, which is essential, will be based on video cameras, photos, looking at the child's steps, the distance between steps, the balance, which is the most affected spastic part of the legs and the body, to give the final good conclusion to which part to work on. And there are other types of assessing the spasticity, like the range of movement, EMG, tendon reflexes, Babinski, which are there. Now, so spasticity is there in children with CB. What are the effects of spasticity on the children? So we've got, it could associate as symptoms, spasticity can associate with pain, difficulties with movement, spasticity and the hip adductors, scissoring, the child will not be able to stand or even to walk. It could interrupt sleep, interfere with daily living activities, mobility, fatigability, because the children will put more effort to mobile or to do things, and also inability to keep orthotics closed or on, because the tightness always pressuring against the splint and causing pain to the child, or at least discomfort, and impairs of the hygiene, as I mentioned, for the hip adductor, poor posturing, and fracture sometimes could happen. Also, sign we could see contractures, poor posture, gait abnormality, lack of coordination. So we do have problems really from spasticity to all children with CB. And because of that, we need to treat spasticity. So spasticity is not good. Now, but the 3 good questions we need also to ask, first of all, why we need to treat spasticity? What are the indications for this? Second question will be when, and then the last question, what sort of treatment modality we're going to use. Talking about why to treat the tone abnormality, most important thing is the function. So a child who's got very tight tendon Achilles all the time on tiptoes, he would have very poor balance and difficulties to walk. A child who has got very tight hip abductor, sorry, he will have difficulties with walking because he'll have all the time having scissoring. So his function is affected. This is the first and most important indication for treatment for spasticity. The second thing, pain. Sometimes children do have a very bad contractures, twisting the elbows and wrist, really painful. So we need to treat and to do something for them. Also with the care, I just mentioned that again, I repeat it. Now a child who's got very tight elbow, family will have difficulty to dress the child and undress. Even some families now we cut the edge of the shirt from side, put zip to it or put some buttons to make life easier for them to dress the child. When to treat spasticity, it's always the severity of spasticity will say that treat or not treat. Mild spasticity, sometimes the children can't survive without causing the children any side effects of our medication. We would need just only to do some basic therapist or therapy, BT, things like that will help. But also will be influenced by the goal. Is there any clear goal for us as functional? For example, I've got a child who's, for example, severely brain damaged, quadriplegic, all the time bed confined, and has got bilateral tightness at tendon Achilles. What is the point of doing surgical release of tendon Achilles for the child who's never going to stand or walk? So are we looking for something really good? But a child who is really mobile, diabetic child, has started to have tightness in tendon Achilles, could not survive and having difficulty with balance, treatment here, it does help him to make his gait and balance better. And also ease of care, I just mentioned some example, positioning, pain comfort, and recurrent deformity as the children having severe spasticity to develop contractures. Now, some consideration for the management, we need always to balance between risk and benefit. Are we going to get a right benefit of this treatment or not? Again, I give an example, the child that sometimes children, their condition does not want to do this very, for example, extensive surgery for them. Hip dislocation is an example in children with spasticity with CB, where that if the child having no pain with it, and the child is, as I said, wheelchair bound, it is a major surgery for the hip. And by the end, when you put the hip back, what the benefit is going to be for the child, and it is a major procedure. Talking about other impairment associating with this. So, for example, a child who is blind, it be sometimes affecting even his therapy to help him to do physiotherapy, occupational therapy, and help and support. But it's also important to rule other contributing factors. Remember, children with spasticity will have their spasticity very much exaggerated with many things. The first thing, looking for bladder, looking for constipation, teeth ache, looking for any infection. So all these things, skin, sore pressure, all these things, we need to rule them out before thinking how to treat. Because sometimes elimination of these contributing factors itself can reduce the spasticity and make the child better without very heavily intervening with the treatment and surgery. Now, spasticity, again, I mentioned that we should consider to treat it only if interfering with some level of function, positioning, or care. Mild spasticity, it often can be treated just only with a little bit of stretching exercises, physiotherapy, and oral medication. And in severe widespread spasticity, this is something really important to consider the treatment all over. So a child, for example, having very bad diplegia with tightness of both knees, tightness of tendon Achilles, you can't treat only tendon Achilles. If you stretch or you do some treatment for tendon Achilles, the child, in fact, will lose ambulation because he is balancing between bending his knees and tightness of tendon Achilles to be able to stand like that. So whenever the child lost his tone, his contraction, his tendon Achilles, he will be falling backward. So when we have sort of multi-level contraction, we need really to be carefully considering what to treat and how to manage all together. Again, patients with significant impairment, mental impairment or cognitive impairment really does affect our therapies. However, that shouldn't hold us back from treating children for the care. So again, the child, even if he's got severe mental impairment, but he's got very bad hip abductor tightness, that we cannot care for the child. We need to treat it. We don't say that he's got mental retardation and we do not treat. Now, the main reason of vortetic spasticity, I mentioned that, I've just mentioned them briefly again. So it is functional, caregiving, comfort, and prevent deformities and contracture, which we came all along with them. And now we have some reason against treating spasticities, sometimes again functional, that some of children would rely very much on mild spasticity to be able to, well, to stand up, to do some things. If you lose that, the child will not be able to stand up. And sometimes it is interesting that, for example, there is a combination I've seen many times that in children having, for example, diplegia, but they do have very loose ligamentous laxity in their knees. So whenever they stand, their knees will be really very loose. So even going backward, but it does have tendon Achilles tightness. If you hardly treat the tendon Achilles, to extend that it'll be in a position where it'll be 90 degrees angle, the child will have difficulties with walking even worse than before. Outside of CB, the big example that children with, for example, Duchenne muscular dystrophy, they have tightness of tendon Achilles, but that is mainly because of the weakness of the anterior peroneal muscle, not of the spasticity in the calf muscles. And when we come to do tendon Achilles release, all the studies show that soon the child put in plaster, he would never walk again. So really, sometimes the spasticity can give some aid and help and support to maintain posture and maintain balance. Again, we need to always balance between the side effects and effects. So some of treatment might be causing, for example, baclofen, especially if you want to reach a good dose to treat the spasticity, you will end up by having neck weakness or even sometimes limb weakness. The last thing is that we need to, before we start to say that we need to treat this spasticity, with what is our clear goal, what is our ambition, what's our goal to do this treatment. Now going to the part of treatment. So spasticity treatment, as I said, we've got different sort of management for spasticity, starting from therapists. Physiotherapy is the most important part of management of all children with CB. And it should be persistent, continuous. It doesn't matter how to be as intensive. I do not believe in a theme of 6 hours daily physiotherapy. It does not work. It is exhausting to the child, exhausting to the family, and to everybody. We need to do minimal physiotherapy, stretching exercises, but maintain it on a daily basis. I most often tell the family they have to be enough to learn what the physiotherapy doing, to do that at home over the weekend, in the evening. Do same things, minor things will have a very good benefit. 2-3 sessions a week will be fine. And most of children we know for CB, when they become beyond the age of 5-6 years, they would have achieved 90% of their ability. Beyond that, doing any extensive or any exhausting courses will not, it might bring an immediate effect. So you could see that after 10 hours physiotherapy daily for 3 months, you could see some effect at the child muscle. But just leave him for 1 or 2 weeks, it will be back to how he was or even worse. Occupational therapy for sitting position, for hand use, that's very important, and orthotics. With the splinting, we do a very sort of continuous stretching. So child having tendon Achilles tightness, putting the child in the AFO splint, it's almost a very good stretching. And also with tendon Achilles, with AFOs, we can help the child that having a balanced gait with, am I okay with time, Ajin? Okay, with a very nice heel strike, so the balance will be better, and that will aid also later. If you give a child, for example, physiotherapy, putting this splint will help to last long. Giving Botox injection also with using the splint, it will last long. So passive stretching of the muscle, as I said, because we know for sure that children growing, that the bone most often will be growing because of lack of innervation to the muscles, that they will grow slower than the bone. And it is very well known that passive movement, stretching the muscle, working with the muscle, will induce and trigger a growing of the muscle and improving. And of course, that will end up by reducing the rate of contraction. Standing frame, it's very important because the children who are able to stand for half an hour to 1 hour a day, that would be very good preventative of developing scoliosis in the future. Of course, other orthotics we need, sometimes we use KFOs when they have very weak knees and other sort of orthotics to help with the spasticity. Medication, we've got wide range of medication, but unfortunately, there is no medication which is clearly safe, that 100% safe. And most of this medication, as dealing with the brain, will be having sedative effects. So the problem with that, and sometimes some of this medication, unfortunately, you need to reach a very good dose, big dose, before you get the effect. And with this big dose, we have the side effect. Starting with baclofen, which is very well known medication for spasticity, and it works on activating GABA the receptor, especially in the spinal cord. And its main side effect, as I said, sedation. With big dose, you have the weakness, bradycardia, respiratory problem, and sometimes they said that if the child had seizure, he might lose his seizure control. Benzodiazepine is the other line. We've got a group of benzodiazepines which can help to reduce the spasticity. Again, the bad side effect benzodiazepine, all of us know that it is sedative. However, I would always encourage my colleagues, especially with diazepam and similar things, that the sedative effects, alhamdulillah, is not persistent. Yani, be patient with the child, giving the diazepam for 2-3 weeks. This side effects as sedation, it will start to become less by itself. And make sure that when you start diazepam, to give a bit of slow increment rather than to jump to a big dose, and that will help the child. We've got a group of benzodiazepine. Diazepam is the most commonly used. I myself, if the child also has, for example, epilepsy, I do prefer clonazepam because it lasts for 12 hours in the blood, which is probably a little bit better. The other, also, there are many other medications like the dantrolene, which mostly used for the in intensive care or anything, but the side effects mostly worry about is the liver enzymes here and liver function. Some of the anti-epilepsy medication like lamotrigine, phenytoin, can help for spasticity, but don't use them never for as this purpose. But as a combination, a child who has CB with the spasticity, they can do some favor, some help. But I don't usually use phenytoin for spasticity as a choice. There are other medications like tenazidine. We've got many other medications which can also be used for treatment. Coming to botulinum toxin, which is really very good indication for focal, when you don't need to spread all the medication all around the body. So if you have a focal, few muscles, spasticity, the Botox could give an answer to it, but we have to be very careful to select cases to which that Botox will help. And the problem is that more level you need to inject, that will be clearly affected with the total dose. Because when we come to this, you've got limitation of the dose, so you start to put bit, small here, it's not going to work. So it's better to be very selective, you know where you need to inject and give. And the other thing, you have to repeat it I usually recommend 6 months, but less than 3 months, there is a high risk of developing antibodies. And the last thing also, I would mention that about the side effects, sometimes allergic reaction, by mistake injection into a vein or artery. So, but these things, alhamdulillah, rarely to happen. I never had this problem. The intrathecal baclofen, again, I said baclofen with high dose, it worked, but cause side effects. So now, other way, if you put the baclofen directly intrathecally to the nerve root, that will reduce hugely the dose, less than 1/10, with a very strong effect. And this also can be titrated. Most often we bring children for assessment. We give them what we call a testing dose. If they show the clear benefit, we can implant. If they don't show, no. This could be filled based on the dose every 4 to 6 weeks by just a direct syringe through the skin. And the battery, it depends how much it lasts for 3 to 4 years as an average. Finish? Okay, I will finish. So intrathecal baclofen, we spoke about it. Selective dose rhizotomy is not very much used. And the basic theory for that is you go to the sensory nerve, bringing from the spindles back to the spinal cord to trigger the movement, to try to selectively cup them. And in this case, you reduce the indication or trigger from the spindle to the muscle to reduce spasticity. Yeah, these are the references, and I would like to thank you very much.